Good morning, everybody. Persons with living with physical disabilities. Disability, as all of you are aware, has now emerged as both a legitimate source and an expanding source of understanding, inquiry, and mainstreaming in a range of issues. And in this process, there is a way in which the terrain between health and disability is a very slippery terrain, and I would like to bring out some of the fissures, some of the contradictions, some of the paradoxes, both conceptual and empirical, that come when we try to look at the issue of physical disability and health. And as we know, from the physical disability is in a way embedded in health, but due to its politics and due to the way in which the movement discourse has developed around disability, there is also a conflict and there's also conflict and ambiguity in that domain. So I'll try to highlight that in the course of my presentation. So these are issues within the larger frame within which we are working, the state withdrawal. I will not go into all these issues, but I want to just highlight here that disability till now, from the public perspective, from the policy perspective, has been largely functioning within a charity paradigm. So this human rights discourse is the turn in disability that took place in the 70s and 80s, where it overturned the idea that these are, we need to work within a welfare paradigm, and the idea that people with disabilities are as integral as part of the population, and the rights paradigm would apply to their mainstreaming and their empowerment. And historically also, disability has largely been the domain of NGOs, it's largely been the domain of service delivery, and within the government sector, as I'll talk about later, it's been again relegated to the social welfare domain rather than the health domain. Now, if we look at the current scenario with regard to disability, there are, in the most recent legislation, 21 categories of disability which have been listed, and this has moved from 7 in the previous legislation of 1995 to 21 in 2016, largely due to the impetus given by India signing the United Nations Convention on the Rights of Persons with Disabilities. So you have a whole range of disabilities, a whole range of conditions which can now have, which have legal ramifications as disabilities. And it's a very mixed bag. You have conditions like the traditional conditions, blindness, low vision, hearing impairment, etc. And then you have conditions now which have been added like sickle cell anemia and Parkinsonism as disabling conditions. But you have other conditions like cancer and cardiovascular disease and TB, which have not been recognized in the Indian legislation as disabilities. So what is the logic of this incorporation? All all illnesses, diseases have disabling consequences, but what is the logic? That is one of the issues, questions that comes up, and something that I have not really been able to figure out. Is it the underlying politics of different disability groups? Is there another underlying health logic to why some health conditions become recognized in others, or is it just ad hoc? That's a question for me. Again, just to, for those of you who are not familiar, which are very few in this room, the extent of the issue of disability at one level invisibilized, at another level when you put another lens of a wide definition of disability, it extends to so much large segment of the population. Over the lifetime, it can extend to every person in the population. If we take the idea of the temporary able-bodied person who at any different points of time may fall into the category of disability, may fall out of it, may be permanently resident in it, etc. Disabilities are increasing. I don't need to go into that. Then coming to the more core issue of this presentation. Like other vulnerable groups, people with disabilities have less access to healthcare services, and therefore experience the whole and a very large burden of unmet needs. And what is this burden of unmet needs is again an issue that needs further exploration, again more research, because as I'll talk about later, there's a way in which we have not really explored in detail from a public health perspective, what are the health issues, what are the health demographics of people with disabilities. Just for our population, I mean, we're dealing with, 125 crore people, 130 crore people. And, in that, if you look at the percentage of people, 2.21 looks very small. I mean, small, minuscule. But in terms of absolute numbers, I think, all of us would agree how vast that population is in terms of absolute numbers. Again, look at the male predominance of males. Of course, there may be, demographic reasons for that. There may be, medical reasons for that. But also, I'd like to just note, if you look at urban India, 2.34 males and 1.98 females. That's a bit of a gap. And my sense is a lot of this is an artifact of gender, where concealment of women with disabilities within the family, for women as kind of symbolic of family honor, plays some, if not a significant role. Population of disabled type of disability, again, this is from the census. It was taken in 2011, and there's a disjunct between the 21 categories that are recognized by the law and the 7, the categories that were mapped in the census. And again, you see here both, a gender difference, and you also see, certain prevalence of seeing and hearing and others as predominant, boxes within a large segment of the population falls. What is this other? It's a huge category, and that's an interesting, from an anthropological perspective, if one had the data, what are the census enumerators, or what is being clubbed in that category of other, that would highlight the cultural configuration of disability in our context. Hearing, it's interesting that a large number of people, I mean, there's probably an age-related phenomenon there, because as I do research on disability, I find that it's very difficult to access people with hearing disability. They are also very invisible. So that's to me that they're coming with a large segment in terms of number 2 is interesting for me. And maybe, I don't know if all of it is related to aging actually. Vision, I can understand. Hearing is a bit of a paradox for me. If we go into disability and health, so what is disability? I mean, it is an interaction between individuals with a health condition. So very core, as I said beginning, that disability is embedded in its definitional context within health. So you have an impairment, you have a condition like Down syndrome or cerebral palsy, and then you have the whole, domain of socio-cultural, political, economic aspects related to it, which define it, which configure it, and then you have the whole environmental issues of inaccessibility, both the built environment, the transportation, and the supports within the social system for catering to the very valid needs of people with disabilities to function in everyday life, and those are really very small at times and very large at other. I mean, again, a huge variation. So you have the conceptual categories that one works with in disabilities: the impairment, the basic biological facet, the biological condition. How does it limit your activity? How does it limit your social roles? How does it limit your opportunities in life, your access to services, education, employment, and participation restrictions? How does it isolate you socially from relationships, from other kinds of interactions within society, whether it's leisure activities, whether it's, occupation of loitering in the street, all those domains which when you don't have there is not a disability inhibiting these are taken for granted, and that's probably one of the reasons that they have to be pointed out by people who actually experience these, because they're so embedded in everyday life that they are naturalized. The disabling concomitants of different health conditions vary. I don't need to go into that. All disabled people, I mean, this is again a truism. They have the same general needs as others, at some level more. which is and even people without disabilities have varying health needs. So that's again a given. Truism, but needs to be stated. And the fact that health is an important issue with regard to disability, highlighted by the United Nations Convention on the Rights of Persons with Disability, that we should work for a higher standard of health care. You would assume that if they're disabled, they are accessing the medical system, and hence this would not be necessary. It would be taken care, which is actually not the case. Disabled people report research across the world, very limited we have in India, but I don't see why it would be any different. Disabled people report more health care than people without disabilities and have greater unmet needs. Health promotion, and this is where I'd like to come in, where what can one do and where can one focus to bring this issue up, that people with disabilities also have healthcare needs. They also need, and in some cases very specific, and in most cases very general healthcare needs. So why is it that their absence in health promotion and prevention activities, in education, for example, in cancer screening or other things, it's been found that, they are neglected. You say, okay, they're disabled. Maybe they're already having access to healthcare. We don't need to do these things. Secondly, there's this idea of a master status of the disability, which means that other healthcare conditions, as a unreflective idea, they're either not there or they need not be taken into account. People with disabilities have, greater vulnerability to secondary infections. I mean, you can imagine mobility impairment and, UTI when you don't have access to, accessible toilets, or you have people with other kinds of conditions which require them to be, bedridden. So, the whole idea of ulcers. Comorbid conditions, like for example, I have glaucoma, asthma I developed while on glaucoma medicines. So, I'm being treated for the glaucoma, which I need the medicines, but I have asthma as a condition which comes from the side effects of the glaucoma medicine. And I have to constantly explain to my doctor when my asthma arises, or my eye doctor refuses to recognize that glaucoma is a side effect because it's not observed in many people. So he thinks, there might be other issues. So, I mean, that's another thing. Age-related conditions, people with disabilities, I mean, not only do you age and become disabled, but people with disabilities have the possibility of premature aging. They may engage in healthcare behavior, I mean, due to, social isolation, psychological, disenfranchisement. Even people with physical disabilities, they may engage in risk-taking behavior, which is as for the general population. And where is the figures? Where is the data on mortality figures for people with disabilities? I really have not seen it. I don't know if it exists. If it doesn't, it should. And if it does exist, I should know about it, but I don't. Physical barriers, these are some of the issues that come up actually in healthcare service areas, hospitals, clinics, all these very physical barriers, accessing the place, the medical equipment, the poor signage, doorways within clinics, and in hospitalization. Sometimes, many hospitals, particularly in the private sector, they don't have the facilities to actually handle inpatients with disabilities with even basic things like toilets. Now, I said there in the beginning that there's a contentious relationship between health and disability, and it comes out of actually the way in which the disability has been configured, particularly in the Western context of it being a very medical category, and hence a lot of, action by people with disabilities to oppose the medicalization, and, medicalization is still a bad word in disability studies, and with the coming of, focusing on the social aspect, that disability is not an individual problem, it's actually a form of oppression, it's a form of inequality. But in that process, the impairment got diminished, and now it's coming back in a way, and hence there is a remedicalization that's happening even within disability studies, where you're saying, okay, there are issues of impairment which we need to deal with. Everything can't be reduced to a social, that we have to address biology. So that's within disability studies. And, the two, like racism, like sexism, you have the ableism and the disableism discourses, which again are not very well established as issues that we need to address, but which we do need to address. The very underlying, socially embedded, almost very difficult to excavate prejudices for people with disabilities, and the construction of society on the idea of the able-bodied person. But if you try to define who is the able-bodied person, who is able, that's again itself a big conundrum, because I don't think there's any definition for it. So that I've already said, the non-disability health concerns ignored, because disability seems to be this overarching sense of they're disabled, they don't have to be positive, the other health issues don't matter. And if they're disabled, maybe other health issues are being taken care of as part of the disability. Unfortunately, genetic research in the current conjuncture is bringing in a kind of new eugenics, where the whole idea, so on the one hand you have ideas of ableism and disableism from the social sciences and the movement discourses. On the other hand, hardcore medicine is actually promoting the idea of selection of characteristics, with the new developments in research. So, we can cancel out disabilities. There's this idea of this optimism going, when, most disabilities, almost 95% to 98% are acquired after birth. So what are you going to do with the genes when a lot of disability, the overwhelming burden is being acquired after birth? But there's this still thing that we can actually maybe eliminate many disabilities, eradicate many disabilities. That's a doctrine that's taking shape very much within the non-disabled population, within the healthcare system. And what does it mean for disability and people with disability? The other issue of paradox is the human rights discourse on disability, which has played a significant role in bringing the issue of disability to the forefront, in giving it its social ramifications, in giving it its socio-political reality, but at the same time, by de-emphasizing the medical, by de-emphasizes the biological, which was necessary, it also means what are the health consequences, what does it mean for the health of people with disabilities, what does it mean with people with long-term conditions which deteriorate over time. That's an issue that needs to be also taken on board. So I am just mentioning some of these gaps that reproductive health, I've already talked about it. Women with gynecological conditions. I know women who have mobility impairment, they say, I have never had a gynecological exam and I hope I don't have to have it, because how will they examine me? And first there's the sensitivity issue, but then there's also the hardcore issue of actually equipment to be accessible for examining people with disabilities, and the knowledge of this, that we actually need to do something. There is an unmet need here. There's an unmet infrastructural challenge. Disability, as I already mentioned, always relegated to in our country, in other parts of the world also, Ministry of Health and Social Empowerment, not a health issue. I'm just finishing. Possibility of forging strategic connections between rehabilitation sciences, cross-disability movement. These connections need to be worked at. There are differences now in ideology. There are differences in perspective. They don't communicate these different areas. And people with disabilities access these. They need rehabilitation services. They need medical services. And they need the power of the social movement discourses. But these different agencies don't come together at times. And lastly, some specific recommendations: inaccessibility of health insurance for people with disabilities. I can't get health insurance. I have so many conditions, but they all get knocked out because when my insurance comes, no, we won't cover this, or the premium is so high, it's better that I just pay out of pocket. This is a need. Healthcare standards and reasonable accommodation related to care of disabled person doesn't exist in my view. Data, as I said, mortality and disability, I don't know. We need more information. And last but not least, medical pedagogy, because that's where it all begins and hopefully doesn't end. Thank you.